So thank you very much. Very good evening to all the esteemed moderator, sir, chairperson, sir, and all the expert speakers. So I would like to welcome all of you in today's webinar on problems in primary angioplasty. And we are glad that today we have Dr. Suni Banerjee, sir, as a moderator for this program. It's my privilege to introduce Dr. Suni Banerjee, sir. Dr. Banerjee sir is the founder and director of SG Cardiac Care, Kolkata. Previously, Dr. Banerjee sir was associated with Medica Hospital and Fortis Hospital, Kolkata as director interventional cardiologist. Dr. Banerjee completed his MBBS from Calcutta Medical College, MD from Gandhi Medical College, Bhopal, and DM Cardiology from PGI MER from Chandigarh. Dr. Banerjee sir also holds fellowship like FSCI, FSCI, and FSCC. Sir has many paper and public active in many important national and international clinical trial as a proctor, and he is a profound proctor. So, I will just hand over this session to Banerjee sir. Please start this session.
Good evening, friends. Welcome to this academic feast. And I am privileged to now introduce the chairperson for the session, who is our great teacher, Professor Dr. S.S. Chatterjee. Briefly, this is not the area where I have to introduce him because he is already a teacher and mentor for many of us. But just to recapitulate his achievement, he did his MBBS from Arjikor Medical College with several medals. And after that, he did his MD Medicine from University College of Medicine in 1978. And he obtained DM Cardiology from IPGMR. And he did his DM Cardiology, and he took the challenge of interventional cardiologists. And from 1986 onwards, he went to the peak in the IPGMR and appointed as the head of cardiology in 2007. And at the fag end of his service, he was a director of Institute of Cardiovascular Science, Arjikor Medical College Hospital, where he set up the cath lab and the full interventional cardiology setup in his tenure. He has received several fellowship in invasive cardiology in France, Rouen, and in US. And he is the most important to know for all of us. He is the most first person, surgeon, doctor to perform valvuloplasty and coronary stenting in the Eastern India. And apart from that, and he did these things when we didn't have this luxury of hardwares, and it's not even in infancy in Eastern India. I may say that it has been just born, the concept of intervention cardiology. Dr. Chatterjee has more than 140 papers in his credit, and 75 papers in academic journals. He was a past president of Cardiology Society of India also. So with this, sir, I introduce sir, and I'll request sir to permit us to go ahead and say a few things about his concept on today's program of primary angioplasty issues. And then at the end, we'll take questions, and sir and me will be happy to answer all the questions, including our two honorable presenter, Dr. Kaur and Dr. Kumar. Sir, please.
Good evening, everybody. I have taken this topic because in this pandemic era, people are afraid to come to hospital except in dire emergency. So most of the PCI we are doing now are primary PCI. But there are some inherent problems with primary PCI, like no flow, slow flow, cardiac arrest, hemodynamic compromise, and so on. We have to be very much efficient in primary PCI because in comparison to elective PCI, we get very little time during emergency of primary PCI. That is, we have selected the topic of problems in primary PCI. We are doing now, everybody in India and abroad, primary PCI, not only in the non-COVID patient, but most of them are COVID. So I expect all our uh, uh, people will be acquainted with it and we will share our views. Thank you.
Thank you, sir. With that, your kind introduction, I will be pleased to invite Dr. Vinith Kumar, who is an interventional cardiologist in Heart Hospital, a busy hospital institute in Patna. And I am surprised to see his plethora of experience from multiple institutes. He did his MBBS from his native state, Darbhanga Medical College, and it is also a very premier institute in India. And after that, he did his MD from Safdarjung Hospital, that is also a very premier institute. And he has been received his DM cardiology from Government Medical College, Thiruvananthapuram, again, the landmark institute. So, Dr. Kumar, we'll pleased to have you on the board as a presenter, and please share your case comfortably. And we have only 2 cases, so we are not having depth of time. So please discuss in detail. I welcome you on the board. Thank you.
Thank you, sir, for such a nice and kind introduction. It's an honor for me to share my case in front of you, so that I will be definitely benefited from my whatever I have done the wrong. You will definitely. Good evening, everyone. This weekend evening, I'm going to share one case of Entreval MI. Actually, it was not a difficult case. It became difficult due to mine idea or mistake, whatever we can say. It is the story of a 41-year male. Did not have any risk factor. He came in our hospital with CAD and Entreval MI with window period of 8 hours. Echo was ejection fraction was relatively 40%, and it's a hypokinesia of anterior and anteroseptal territory. That patient's angiogram was there. That RC was non-dominant, and LAD was having a very tight lesion after the diagonal, and after that mid part, there was no flow in the LAD, and the circumflex have the CTO was there. Circumflex was dominant circumflex with one CTO. So we have first decided to open the infarct-related artery, that is LAD, so that we can establish the antegrade flow in the infarct-related artery. We have engaged the left main coronary artery with the EBO 3.5, and we have taken Felder FC wire to negotiate that lesion. That lesion was relatively difficult to negotiate. So we have taken a small balloon support for that, because wire was not negotiating. With the help of balloon support, I can able to negotiate that lesion. Initially, I have dilated the artery with the same small balloon, and after that we have serially dilated with a bigger balloon, 2.5 50. After balloon dilation, we can able to establish the flow in the LAD. Now I have some dilemma in my mind. What shall I do? Because that circumflex dominant CTO was there, and there was no any definite history how That means how many month back it was occluded. So I was thinking, shall I leave that patients for either bypass surgery or we can go for multivessel angioplasty. Main reason that circumflex dominant CTO was there, so I think it's better we can send that patients for bypass, because I was thinking flow in the LAD was okay. So after integrate flow, we have established and we'll send that patients for early bypass operation. After removing the wire, flow was totally occluded and again it become dissimilar like before. Now the main difficulty, I have to rewire the LED, and I already dilated that artery with a bigger balloon also. So definitely there is some dissection will be there. So I again tried to rewire. It was very difficult to wire, and wire was not going. So again I've taken the small balloon support. With that balloon support and by good luck, I able to negotiate or rewire that LED that we can see in that last paternal part. It was in the lumen, true lumen. After that, I have again dilated with a small balloon, but I cannot able to establish the flow. So so it was definite. It is dissection, and I was thinking distal part is in the true lumen only. So I've taken a bigger stent, 2.75 48, and I inflated that stent. After inflating, I able to got the flow in that artery. But after that stent, one more lesion was there, so I have covered that lesion with a smaller stent, and after that post dilation, flow was reasonably good. And one more lesion was there, but I was thinking it was borderline lesion only, so I left that lesion as such. And in the LED flow, flow was good. That patient become better after that. Symptom is also subsided after that, and that patient's hemodynamic was okay. Renal parameter was also good. So we have decided to do that LCX CTO also in the same admission after stabilizing the patients. For the LCX CTO, again we have taken the radial only. For the initial, I just want to feel how tough was lesion. So I've taken with the filter FC wire. Wire was not negotiating, so I've taken a small balloon also, but it was difficult. Wire was not going. So after that, I have taken the Asai Gaia 2 wire. That Asai Gaia 2 have negotiated that lesion. And after that, our work have become very easy. We have initially dilated with a smaller balloon, then followed by bigger balloon serially. And after that, Gaia 2 wire has been exchanged with the filter FC wire. And we have stented the distal part first, then followed by one more stent with the overlapping the distal stent. And after that, we have dilated that lesion, post dilated. And this was the circumflex flow we got. LED was also reasonably good. So follow up now it's almost become more than 1 year. That patient is doing well and he is coming for regular follow up and no symptom was there. Take home, I did not have anything much to say, but with cath lab decision need to change according to the situation. It was my mistake. I removed the wire because I was not very much confident at that time to do the L6 CTO. That was the reason for that. If we stay calm, we can able to achieve reasonably good result.
Take action. Sound take action.
Sorry, sir.
Sir, you can give your opinions.
Yeah. In this case, why he did not try with ordinary uh, angioplasty wire instead of taking filter XT?
Not, sir.
Because
It was not filter
the
XT.
primary.
No, sir. It was filter FC only, sir. That was routine wire, not XT, sir.
Oh, filter XT.
Yeah,
And
yes, sir.
what
Yes.
was the reason for the dissection?
No, dissection was probably that lesion I have dilated with balloon with almost 14 to 16 atmosphere of the pressure, and most likely lesion definitely it was 80% or 90% superimposed on that acute thrombus. That might be the reason for dissection, most likely, sir.
Why did you give so high pressure during initial dilatation?
No, sir. Initially, I have dilated with a smaller balloon. With dilation of a smaller balloon, I cannot able to achieve the flow, sir. That was the reason I've taken the bigger balloon and I've dilated at high pressure. Initially, I was thinking it's okay if we cannot. Our initial intention was to achieve the antegrade flow, so that we can able to save that myocardium territory, sir. But after establishing the flow, I have some dilemma, so that we can able to completely revascularize, because circumflex was CTO, RC was non-dominant. So it's definite to revascularize circumflex also, so that we can, and age was also relatively younger patient, 41 year only.
Okay.
My thinking is that your dilemma, what is not written in your science or you are not saying, probably the dilemma why you had that to send this patient for bypass surgery is because of financial constraint, and that is really a problem for most of the patients. And at the time
Definitely.
of primary angioplasty, you don't know how much fund he has. He may have just accumulated some amount. So this
Yeah,
is a
hybrid.
problem. This is a problem what we all faced and we face daily. And this is really a challenging situations for people who are practicing not for a long time. They also face this problem. People who have just started their practice, they also feel the problem. So this is a common issue. Now I think your dilemma was probably because of that. And if
Yes,
you're
sir. Hybrid procedure, we will not afford.
yeah, and the ST elevation, if they are in the ECG, then there is no point to wait for a bypass surgery, because the surgeon always will wait for the enzyme to calm down. Now, I just clarify 2 points what sir asked you. Till now, filter FC as a tapered tip where it's fine, but the terminal portion is a little bit more opaque. So it is difficult, and you have to give a little bit more dye to visualize the diameter of the distal vessel. So we all will be happy to have a conventional floppy where if you don't have a microcatheter with a balloon support, we can cross. The other thing in this case was that it was already getting collateralized, and probably these patients actually what they say is they don't have any symptoms. They fail to understand what was happening. But you have done the things rightly. And the second point, what Dr. Chatterjee was saying, sir, that the high pressure balloon dilatation
What
in
is
the
the
setting of primary angioplasty better to avoid, because we have burned our finger by seeing that we have achieved with a great difficulty some flow, particularly in right coronary. And the moment we thought that we'll give a bit bigger dilatation, and we just ended up in narrow flow, and we never been able to come up with this. So probably your end result was extremely good, and your stage procedure for LCX CTO is also well validated. And the thing is very clear that we learned again that primary angioplasty is the crux in patient with acute MI. So if we have any other, and why you can put some question, you are one of the next
Thank you,
presenters.
sir. So, firstly, Vineet, it's a very beautifully done case. I mean, congratulations for the fact that you decided to stage the L6. One very interesting thing, I think even Shunit sir would agree with me, that is that if you look when you started doing the L6, your distal LED had already grown. What looked very diffuse in your very first shot in your initial state where you were thinking that the LED is diffusely diseased, after putting in your stent and the fact that you had flow-related dilatation in the distal LED, your distal LED looks very nice when you started doing the L6. So that is something again to stress upon that sometimes in these diffusely or chronically diseased vessels, they generally tend to remodel, negatively remodel. And so once you open up and you get flow-mediated dilatation, these actually gain their proper sizes. So which is why sometimes imaging helps in these kind of vessels to actually find out what your distal vessel looks like so that you don't end up overstenting. So, but that was really well done. I really appreciated the fact that you took the trouble of rewiring that LED.
Yeah, that's really good. So my next task is to introduce my second speaker, again a dynamic cardiologist from R.N. Tagore Hospital, and he has done his DNB internal medicine and DNB cardiology. We all know DNB cardiology clearance is difficult. He did it in first chances, and he's a full-time worker in this busy hospital, and a person who is devoting all his time in a busy hospital has more experience in his bag, which he will be able to understand after decades. And as from his version, he is a regular user of the imagings like IVAS and OCT. And what Dr. Owen said rightly, if I would have the luxury, I would have used the IVAS in this case definitely to see the distal vessel and to minimize my stent length. And probably even many a times we need not do a post dilatation if you have the IVAS. OCT also he is very proficient in doing, and apart from that he is trained in device implantation and PTMC, although we are not doing very regularly, but he is smart stud in doing his this, and he is academic person in R.N. Tagore Hospital, and I am glad to invite on for your case, please.
Thank you, sir. Thank you for those warm words of introduction. So I will be presenting a difficult case which we did in this COVID scenario. This was done about somewhere in the middle of last year, in the middle of lockdown. So as you will appreciate, so we call it the complex double bifurcation stenting. Often in COVID situations, you find these kind of patients presenting with unstable angina. There are a lot of issues here. The surgeon wants double COVID tests. Patient has a lot of lung issues. Patient is coughing, has chronic COPD. You're not sure whether it's COVID. A small bout of fever. Surgeon says that, okay, I'm not going to operate on this patient. So this one was a 71-year-old diabetic smoker with COPD who presented with unstable angina and chest discomfort radiating to the jaw on exertion. So his baseline LV function was normal. He's a hypertensive and diabetic, and as you can see, his A1C is fairly controlled at 6.9. Hemoglobin and creatinine is normal. His fasting blood sugar on presentation was about 112. So let's look at his angiogram. So I think you know why we are now concerned. So this is the kind of angiograms where you would really want to call the surgeon sometime. So you can see a distal left vein out here. There is tapering of left vein out there. There's an ostial LAD. There's an ostial LCX. You can see that there's some amount of disease in this large OM out here as the ostial LCX. So and something which is similar out here too. So here also you will see that the disease is quite significant and diffuse, especially in this part of the LAD. So now the question is, so we decided to send this patient for a bypass. We had a heart team convened in our hospital. The surgeons were ready, but the patient backed out, saying that that he wouldn't want his chest cut open, and at this age he was a little frail. He had bad lungs to start up with, but definitely didn't want to undergo bypass. So we had to plan a procedure for him as far as we were concerned to go ahead and do the stenting. So now question was, what all do we stent? So we had this ostial LCX, we had that distal LMCA tapering into the LAD. You can see that ostial OM1 also diseased. And you will also see that the distal LCX also, it's quite caliber wise quite significant, and there's a disease there too. So, and since whenever we do left main diseases, I always prefer to take a intravascular ultrasound. We do have the luxury of an intravascular ultrasound in our lab, and so we decided to take a pullback from the LED to the LNC. And as you would note out here, that somewhere around the proximal LED, there's a lot of diffuse disease out here, and the same thing that you can see the specks of calcium out here, and the distal LNCA seems quite okay, and it's nicely disease free. So we decided, so we need to do the LED. So now question was, we did a LCX to LMCA pullback also, and as you would see that here also, this was our landing zone in the L6. As you can see, normal landing zone with very little plaque out here. This is the tightest part. As you can see, this is exactly a fibrofatty with specks of calcium out here, and it's quite significantly truncated lumens out here. And then of course that is the LCX ostium, which is also very significantly diseased and with a plaque volume of almost 76%. So now question was, what technique to adopt for what? Now that we have to plan to stent this part of the LCX, we had this OM1 and we had an LED to left main to do. So we also had to ensure that the procedure was simple, and that we could actually manage to do it at one go. So we decided, so let me proceed and show you how we went about this case. So first we decided to wire the L6, and we pre-dilated with a 2.75 into 12 and a 3 into 12, and at high pressures to ensure that we have, as you could see, there was a lot of fibrocalcific plaque there with specks of calcium, so it needed good bed preparation. So and since we knew the diameters, we chose our balloons wisely, and we've pre-dilated adequately to ensure that we made a very good preparation to land our stents. And after that, as you can see, we pre-dilated the OM1 with a 2 into 12. And after pre-dilating into the OM1, you can see that there's significant improvement in the flow in the OM1. And so that is how it looks now. So we have a wire in the OM1, we have a wire in the LCX, and of course the wire in the LED stains. So first we decided to do, this is a short T-stenting to the LCX, and that you can see is the OM1. We decided to take 2.25 into 24 millimeter DES at 11 atmospheres. And that, as you can see, we've already placed a balloon into the LCX just across the ostium of the OM1. That is to crush the little bit of protrusion that is there of the stent in the OM1. And after that, once the LCX is, once the OM1 stent was deployed, we decided to crush it with a 3 into 12 LC at 11 atmospheres, ensuring that we have enough place for the next two stents to land. So we've gone ahead and we've decided to put a 3 into 28 DES in the distal LCX. And then, of course, we've decided to adopt the culotte technique for the left main. So we've decided to pre-dilate again. We decided to put another 3 into 28, 3.5 into 28 into the L6 into left main. Then we've recrossed our wires and through the L6 stent into the LED, and we've again pre-dilated the LED with a 3 into 12 NC. And that is how the stent is positioned into the LMCA to do our final pull-out to ensure that we have enough stent inside the left main for our final pot. And so that is rewiring the LED through the LCX struts. So once the LCX struts again have to be rewired through the LED stent, and pre-dilatation of the L6 stent strut, then 3 to 12 NC LED and 3.5 into 12 NC into the L6. And we go 12, 8, 8, 12, and then finally, so that is how on stent boost, that's how the balloon placement looks out here. And so this is the stent passing through the LCX struts, and you will see that it's the fact that we pre-dilated the struts very well. It makes a stent passage very smooth, as you can see. We are generally gentle and we are slow, and we generally just pass it through the struts of the LCX, and we position it in such a way so that we are into the left main. And that is how the 3 to 32 DES into the LED looks like, and that is after crossing. And this is difficulty in passing the balloon into the L6 after recrossing into the L6. So this is very common of doing bifurcation left mains. Sometimes this of course was after we used it once. So the second time we're trying to use the balloon. So the profile of course is not as good as the first one. So but as you see, if you persist at it for some time, it generally goes across. And then we did the second KBD out here. After doing the second KBD, we've done the final pot into the left main, and that is with the 4 into 12 NC at 24 atmospheres. And that is our final result, and I think that looks fairly decent. Of course, you can see again the diffuse amount of disease in the LED out here. We had the ability to actually look into the disease out here, and we basically found it to be a chronically negatively remodeled vessel, which is why we haven't put any stents in this part of the LED. So the final IVUS looks somewhat like this. So this is as per Kang's criteria in the left main. So we have the distal LCX osteal where we have attained this thing of MLA of 6.7. In the LED osteum 7.5. In the polygon of confluence 9.31. And in the left main you've got a 12.16. And that hopefully should prevent recurrences of lesions or target vessels or target lesion revascularization in the long run. So the idea of putting across is that whenever we are planning for a left main PCI, it is absolutely essential to have an IVUS, a pre-IVUS assessment. Whether you do a post-IVUS, it's not probably as important, but a pre-IVUS assessment is absolutely important. And it's extremely important to plan your procedure and attain good MLAs to reduce TLX in the future. Thank you so much.
Sir, your comment, please.
Are you telling anything?
Yeah, your comment, please.
Yeah. This is a very complicated case with so many lesions, and decision was good, and the case was also done well. You talk.
Okay, sir.
Yeah,
Okay, sir.
my take on this case is two. One is that is the right coronary artery non-dominant?
Yes, sir.
Oh, okay, it's non-dominant. Fine. So this is good. Actually, you think that with the recent evidence of decay crush 6-7, you could have thought of that, or
Yes,
Coulott?
I absolutely agree, sir. DK Crush 6 actually has evidence that DK Crush is better than Coulott probably in the left lane, but it would have made it a much more complex procedure.
I
Because we
agree.
already did one bifurcation in the LCX OM, so I wanted to keep the left main OM something that is easier to do. So I thought the Coulott here would be easier.
No, I absolutely agree. And why I said so, because when I compare these two, forget about the long-term result, those minor statistically significant or non-significant difference in Coulott and decay crush. That's not the thing. Issue is that your actually long-term result of bifurcation angioplasty with root stent strategy goes by only one thing: if you can do a successful final kissing balloon inflation, what you could do in this case. Now, if you have done a decay crush, it is easier actually to do the FQBI. What I have learned from my mistake in Coulott, what happens that you put the LED stent, you have made a very good orifice, but still it is difficult for the circumflex to get engaged. But in this case, it was done absolutely nicely. That's not the thing. And the other thing is that your IVUS information also said one thing, that it's significant plaque volume, but fortunately, looking at his age, the calcium burden was not very high, and that's probably you will get a very good age over a period of time. And putting two stent strategy was the right option in this case. Absolutely. My one question to both of you: what antiplatelet you used? I mean, Vineet, in your case, it was a primary one.
Yes, sir.
So
that,
this is again a complex angioplasty. If you see the DAPT score, it will be high. And in Oyan case, it is may not be a primary, but it's a complex, and he is an elderly fellow. So just wanted to share your thought process, how you handle the antiplatelets.
all primary, sir. In our center, we are giving the newer antiplatelet only. At least we want to give for 1 year, but we are seeing few patients. Almost half, they are usually difficult to continue for 1 year. They are usually asking to switch over to some other antiplatelet after some time. In that scenario, we are switching, but usually we want to continue for at least 1
Yeah,
year.
it is better to switch rather than they stop
Yeah,
themselves.
discontinue. That is better.
It is better to
And
switch
for
rather than they
this
stop themselves.
complex lesions, just like bifurcation or multiple stent we are using. In that scenario also, we want to use the newer antiplatelet if they can able to afford for 1 year. Otherwise, for initial 1 month or just like initial sometime 3 months, we want to give. After that, we are switching to that.
Absolutely. And what you did in your case, what antiplatelet you gave?
Sir, I have given ticagrelor, sir. So since, as you could see, there's a significant amount of stenting, we had a left main bifurcation, and it was an unstable angina background. Or I mean, it had a mildly raised troponins to begin with. So I think in that case, the maximum benefit or the burden of evidence is actually for ticagrelor. And given the fact that we have a lot of generics available right now with ticagrelor, it has become marginally easier to prescribe ticagrelor for maybe a longer time. Marginally
Absolutely.
easier.
Absolutely. Maybe we can continue for a long time even.
True, sir. True, sir.
So it's a great case, sir. You have anything to say as a closing remark?
Yeah, since I am seeing in my present institute both bypass surgery and complex angioplasty, and problem with the patient in bypass surgery, it is a very big operation. So it is better for us to switch to angioplasty, complex and more complex, so that patient will be benefited, their morbidity will be less, and procedure of angioplasty will be more and more popular. That is why I congratulate Dr. Kaur that he did this complex angioplasty, and if the patient is benefited, they will like it.
Yeah,
So this,
absolutely.
uh,
And the more important thing is for Bineet and Dr. Ryan both, that if you have done your job as of 2020 standard, international standard, so there is nothing wrong in that. And then the gap between these two procedure becomes narrowed down very drastically. So go ahead, and I welcome you all again to present more
Not only,
cases
sir,
in future.
for the bypass, if it is the arterial graft, that is okay. But if we are going for the venous graft in other two artery, that is usually more commonly we are seeing. Their fate we all know very well. It's not like that, like arterial graft. Definitely, our stent will working for a longer than the venous graft. There is no doubt for that.
Absolutely, absolutely.
sure.
Oh, absolutely. Yes. About team, you have anything to say? It is all your presentation today. So if you can wanted to have some concluding remark on this after these two excellent presentation.
Yeah, it's audible, sir.
No, no, we are talking to Atanu. Atanu, I think you are muted. Right.
Yeah.
So, sir, I think we don't have any questions from the audience, sir. So now I would request Dr. Chatterjee sir to just conclude the session. So it's a short and scripts session. Because of COVID time, we also keep it very simple, and only two presenters we have kept. So Chatterjee sir, your final comments, and then you can close the session, sir.
Actually, what I told already, that benefits of PCI and angioplasty are more superior and less causing for the patient inconvenience. So patients are now liking angioplasties more than bypass surgery. And we, the cardiologists, should be more efficient to deal with the problems of angioplasties, so that more and more patient will come forward. And what Dr. Bineet has told is very important that venous graft has no value. It can close by the same day. So it is better to put stent than to put a venous graft. That is why our cardiologists now will have to do a big job everywhere, particularly in India, because surgeons are less here. Compared to that, angioplasties are more available, and people also like that. With this, I want to conclude this session.
Thank you.
Thank you all.
Thank you, sir.
Thank you, sir.
Thank
you, sir.
you. Good night.
Thank you
Stay
so much,
safe,
sir.
sir.
Thank you.
Good night, sir.